When we talk about the repair of heart valves, it usually concerns the mitral or the tricuspid valve, very rarely the aortic valve, and never the pulmonic valve. Therefore, I want to put the main emphasis in this chapter on the repair of the mitral valve, a technique which is now increasingly being performed, at least in those patients where it is possible, and a technique which has greatly impacted cardiovascular surgery. The younger audience will probably not recognize this movie anymore called The French Connection, a movie that came out in 1971 and which was actually a cult movie. It featured Gene Hackman in a detective story. But what does this movie have to do with mitral valve repair? Well, quite a lot, because in 1980, Alain Carpentier published a paper called The French Correction, where he first described the technique of mitral valve repair. Alain Carpentier is certainly a living legend with respect to repair of the mitral valve. He not only pioneered the technique of repair, but he also helped us to understand what the mechanism of mitral regurgitation is in the first place. In addition, it was he who actually proposed the classification of the anatomy of the mitral valve, the famous Carpentier classification. Now, the surgeons are quite creative when it comes to inventing new techniques for repairing the mitral valve. Of course, it's very difficult to know all these different techniques, but there are a few ground rules and a few techniques which are commonly used. It's important to know these techniques because, after all, we have to interpret them with echo. Now, what do we need to know? First, mitral valve repair is almost always combined with annuloplasty. Second, the most commonly technique for the posterior leaflet is resection and sliding plasty. We'll talk about that later. Third, for correction of the anterior leaflet, the prolapse of the anterior leaflet, usually, or what can be used, is the so-called chordal transfer technique, where parts of chordal structures which belong to the posterior leaflet are transferred to the edges of the free edges of the anterior leaflet. Fourth, there's also the possibility to use artificial chords, so-called chordal replacement techniques. And finally, the Alfieri technique, where the anterior and the posterior leaflet are just simply stitched together, creating two orifices. In principle, this method is also used for the interventional approach to repairing mitral valves. But why a ring in the first place? Well, this question has obviously nothing to do with marriage, yes or no, more with the competence of the mitral valve, because a ring prevents annular dilatation. And annular dilatation can still be a problem even if a valve is repaired. Usually, or most frequently, we have the posterior leaflet which moves away from the anterior leaflet, and the annulus gets a more circular shape. To prevent that, a ring is inserted, and therefore the valve orifice area stays the same, and we do not have secondary regurgitation caused by annular dilatation. So, in other words, a ring is implanted both in the setting of primary MR and secondary MR. There are many different rings out on the market, and I guess it's a preference of the surgeon which ring is really implanted. One of the first rings that were used, and a ring which is still frequently implanted, is the so-called Carpentier ring. It is open on one side. And then there are rings which adapt to the anatomy of the mitral valve orifice, and also which are more flexible and therefore can adapt to changes in the orifice during systole and diastole. Such rings are also nicely visible with echo, both in a parasternal long axis view, but also in apical views such as the 3-chamber view or the 4-chamber view. Those bright echoes here, this is the ring in a patient with a repaired valve. We'll hear more about how to recognize a repaired valve later on in a demonstration. But first I would like to show you the most frequently used technique to repair a mitral valve, and also how this technique relates to what we see in the echocardiogram. I would like to show you how this procedure works on a drawing. First, here we have the mitral valve, which has the shape of a peanut. This is the line of closure and the commissure, anterolateral and posteromedial. And then remember, we have an anterior leaflet, which is larger, and a posterior leaflet, which is here. Now the procedure is usually performed if we have a problem in P2. So let's say we have a prolapse here, and then the surgeon would just cut this region out. Okay, so this is basically just cut out. So you end up with a hole here. Now, it's not ideal to just close it with a suture line because then you'd end up with a fold. So what is then performed is another cut along the ring. So the posterior leaflet is mobilized, and then these two ends are kind of drawn together, okay, from both sides, and then a suture line is placed to close the gap and also to close the region where the ring was mobilized. And then finally the procedure is concluded with the ring. Note that the ring is placed a bit inside the valve, so the area of the valve is now smaller than it used to be, and therefore we also have a fairly small posterior leaflet. So the length of the posterior leaflet is significantly smaller than what it used to be, and this can also be nicely visualized with the help of echo. And the ring helps to stabilize the valve, so the valve just simply cannot expand even after the procedure has been performed. So this is how the sliding plasty and the resection of parts of the mitral valve are performed. From this sketch, it should become apparent that you have two prominent features present in patients who have repaired mitral valves. The first is the ring, and the second is a fairly short posterior leaflet. Watch the following demonstration and see for yourself. So how do we actually know that the patient has a repaired mitral valve? Actually, we should know from the referral, but from my experience, we often do not get the information, and the patient had some other form of cardiac surgery, for example, bypass or aortic valve, as in this patient, but also a repaired valve. So let's take a look at the 2D image, and let's take a look at what we actually see. Well, the indicative sign of a repaired mitral valve is the ring, which is always implanted together with reconstruction or repair of the valve. And the ring can be seen as very bright echoes here and here. So the orthogonally hit ring can be seen at the rim of the mitral valve. What is also typical of a reconstructed valve is that you have a fairly short posterior leaflet. So the long leaflet, the anterior leaflet seems to be the one which is mainly involved in closure of the mitral valve, and the posterior leaflet is rather short. To be sure that this is not annular calcification, which could look very similar, all you have to do is go into the short axis view, and if you do so, you can nicely see the ring, which is semi-annular, which is open here. This is a Carpentier ring, and this is very homogeneously thickened and not as you would expect it, for example, in patients who have annular calcifications. If we take a look at the ring from an apical view, we can also see the two bright echoes here in the lateral and medial portions of the valve. And this can also be seen if I go to an apical long axis view. One bright echo here and another bright echo here. So this is a classic reconstructed, repaired mitral valve. Now that we know how to recognize mitral valve repair, we have to ask the question, what are we looking for in the first place? Well, primarily for residual regurgitation. But other forms of complications include ring dehiscence, obstructed LV inflow, LVOT obstruction, and especially in the setting of fever and infection, endocarditis. It's time we see a demonstration. A patient who has the most frequently encountered complication following mitral valve repair, residual mitral regurgitation. So let's take a look at this patient who had a repair of the mitral valve 11 years ago, which was initially successful. And let's take a look at the color Doppler signal. We'll do that primarily in the apical views. Let's just turn on the color here. And immediately we see that there's a regurgitant jet which originates here at the center of the valve, going through the annulus
And looking at the severity, if we quantify it semi-quantitatively, I would probably say this is at least moderate. However, if we tilt the transducer a bit, we can also see that there's a second jet which originates outside the ring, which is in other words periannular, and which is maybe a bit smaller, but in summary, if we combine this jet and this jet, and if we add them two together, this is probably moderate to severe regurgitation. We can tilt the transducer and turn the transducer in all different angles and ways just to get a better appreciation of the size of the jets, and you can see that this is not just a hole, but it's actually more of the circumference of the ring is involved in regurgitation. And if we look at the ventricle, you'll nicely see that it is actually dilated and hyperdynamic. So this too speaks in favor of a significant regurgitant jet. And coming back to the continuous wave Doppler signal in this patient, we can also see that the gradients are elevated. We had a mean gradient of 8 to 9 millimeters mercury and a velocity of almost 2.4 meters. So this all speaks in favor of a significant regurgitation despite the patient having been reconstructed or repaired.
So when you assess regurgitation following repair, it's not much different from assessing conventional regurgitation. You look at the proximal components of the jet, the gradients. You can look at the mechanism, which however is often very difficult to really determine what the problem is, and also at left ventricular function. And basically it all centers down to the question, does the patient need repeat surgery? Even though the indications for surgery are quite similar to conventional MR, the decision is often very difficult. In addition, the mortality is elevated because it is repeat surgery. And after all, who wants repeat surgery in the first place? In the end, I guess it's always an individual decision whether we should reoperate, and if yes, when. This here is a patient where we had to reoperate because the patient only recovered very slowly and still had significant symptoms. What we see here is we see partial dehiscence of the ring. Note that we have an eccentric jet, which we probably underestimate with respect to its severity, and which flows around the ring. So we have a component of the jet which passes right up here outside the ring. This is another example of a paraannular MR. However, this time it's the posterior ring which has a problem. We can see the jet here outside the ring. And here we have an almost complete dehiscence of the ring. You can see that the ring is only attached on a small portion to the posterior ring of the mitral valve, and the other part of the ring moves freely up and down. And you can imagine that this patient has severe regurgitation. I think here there is no question. This is a clear-cut indication for repeat surgery. Fortunately, this is a very rare complication, but it does show you how powerful echocardiography is to detect such problems. Now let's turn to the assessment of mitral valve inflow. Remember, we place the ring, which is somehow undersized. So a potential problem is that the undersizing was performed too drastically and that we now have obstruction to inflow. This can be detected very similar with echocardiography with the help of Doppler and with the help of the mitral valve inflow spectrum. To detect and quantify this problem, we don't do anything different as we would in mitral stenosis. Watch the following demonstration and you will see.
So to evaluate the Doppler across the reconstructed valve, we would go to a 4-chamber view, and we would place the Doppler sample volume here at the tip of the leaflets with the continuous wave Doppler first. We'll optimize the image. And then we would actually go about the same way we would do in mitral stenosis, where we simply trace the curve to quantify the gradients. So we would have a maximum velocity of 2.2, which is more than would have a normal valve. and we would have a mean gradient of 8 millimeters mercury. And then in addition, we would perform a pressure half-time measurement, which is very similar, again, in mitral stenosis with 86, which means there is actually no obstruction, but there is elevated forward flow. We'll talk later why this patient has an elevated flow across the mitral valve. So looking at the Doppler here, we can quantify the degree of possible obstruction just the same way as we would do in mitral stenosis.
Another potential complication following mitral valve repair is that of LVOT obstruction. Why can that happen? Mainly because the anterior leaflet is left too long. This can happen especially in the setting of mitral valve prolapse, where we have a lot of redundant tissue, and if we undersize the ring, and therefore much of the anterior leaflet is kind of displaced towards the ventricle. This situation is very similar to hypertrophic cardiomyopathy, where we also have LVOT obstruction. We don't see this complication very often because the surgeons are now aware of the problem and prevent it by just not leaving the anterior leaflet as long anymore. But what are the predisposing factors? Well, I already mentioned the redundancy of leaflets as we see it in myxomatous mitral valve prolapse. Then also in small hyperdynamic left ventricles, especially in the setting of hypertension or additional aortic stenosis, and if we have a very small annulus due to undersizing of the ring. So in summary, even though mitral valve repair is a very good operative technique which preserves left ventricular function and where we do not need anticoagulation and which is there ultimately very good for the patient, it's a very tricky operation and you need a good surgeon. But you not only need a good surgeon, you also need a good echocardiographer, because echocardiography is not only performed after the procedure but also during the procedure with the help of transesophageal echo. And usually, if complications are present, they are detected during operation and corrected during operation as well. So, usually we don't see very many complications following repair. If we do see complications, it does not necessarily mean that the surgeon failed. It could also be that some event happened after surgery, for example, endocarditis. And exactly this disease entity will be the topic of the next chapter.